So this is the left ear and transcanal approach for a pure conductive hearing loss, unilateral one. And I'm now exploring the middle ear cleft. I've done already the bony rim section, so you can see the facial nerve running here, and the stapes and the incus and the malleus. I've already separated the incus from the stapes here, and you see that I'm checking now malleus incus mobility, which is fine, and the stapes is fixed and malformed. You see, the problem that we have is we have a single Causse stapes. So the point here will be to, of course, remove the superstructure and then perform fenestra. The problem is that it's a very narrow oval window, so I will need to do it very slowly and very gently. So now we're going to try to drill out the posterior part of a unique single Causse, which is pretty tricky because you see we have a very narrow gap here. So I need to start drilling out like this, trying to drill out transversely the superstructure. And I have to do it very gently, step by step, because I have, of course, the facial nerve on the other side. We have a thick superstructure, the Causse, single Causse, very, very thick. So you see what I'm doing. The point is that I want to access the level of the foot plate, and I cannot do better than this at the moment. Donnez-moi du sérum, s'il vous plaît. So it's going to take a long time, and you see some very small persistent stapedial artery, but this is not a danger one because it's a very small one, but it's not dangerous. The problem that I have is due to the very small gap that I have. Okay, so I just leave the diamond dust doing the job by itself, and I must say that the superstructure is pretty strong. There's no rush. You see how thick it is. Once I will have removed part of this, I will be able then to drill out the residual Causse, the residual superstructure, trying to go down up to the level of the foot plate. But of course, this is a very progressive process. Du sérum encore, s'il vous plaît. I think it's nearly done. It's not too bad, but you see how big it is and how thick it is. I'm trying to stabilize the superstructure at the same time. I'm pushing a little bit on top of the incus. I cannot do better than this anyway. It takes time, but it's not a problem. And of course I'm checking the facial nerve on the other side. I need to drill out posteriorly again because I think this is still there. This is still some bone there. So I'm using a 0.7 millimeter diamond dust burr, and at the moment 0.9 millimeter sucker. So I think it's nearly done. We have some residual attachment at the anterior pole of the foot plate. So if I drill out transversely, vertically like this, I think I can get it. Yeah, I think it's nearly done. You can see it's a loose now superstructure. Okay, I think it's done, but I need to check. 3 de choux, s'il vous plaît. But you see what we have is a really thick foot plate underneath. Crochet à os. Attendez, je vais prendre de l'autre côté. That's the anterior pole. I could not separate entirely the joint because it was pretty thick. Of course, I don't want to dislocate the incus, so I need to do it very gently. Trop de chouk. I want to preserve the incus. We have some kind of attachment here. You see the big stapes head that we have? Now we go. Alright, so I remove that, and now we have access to the foot plate, but it's not an easy access. You see what it is? Thick. So again, I'm going to drill out all these things, trying to perform a progressive fenestration of the labyrinth. So to do this, I need to drill out progressively, very progressively, the foot plate area. I'm not going to measure the distance now, because of course it's not the right level of the foot plate, because I've got some residual superstructure, some residual crus, so I need to thinner all this area. And you see, again, I do it very progressively without any rush, just leaving the diamond dust doing the job by itself. And in fact, the laser would not be efficient in this case, because you see how bony is this area. Un peu de sérum encore, s'il vous plaît. So it's a step-by-step procedure. If I use the Cremers classification, Teunissen-Cremers classification, this is a class 1, which means malformed stapes fixed, without any other malformation. So Malleus incus, of course, are fine and mobile, so it's pretty good. So what I intend to do is to perform a stapedotomy through this malformed foot plate, then put a vein graft, and then a Causse piston. You see it's becoming better and better, but still it's very thick, so I just enlarge a little bit the drilling. And I don't put any pressure on the foot plate, of course, because I don't want to dislocate such a strange foot plate. So there we go. I think it's going to be pretty good in a second. Un set, s'il vous plaît. I think I can measure now the distance. Mesureur. I will measure from here. There is a bit of a beginning of a fenestra right here, so I'm measuring from here, and at the moment this is less than 4, but I think we're going to go at 4 for sure. So now I'm using a 0.7 millimeter suction tube sucker. I need to enlarge the fenestration here. This part becomes mobile, I think. So if this is the case, then I will leave it like this, just cover it with the vein graft, and that will be fine. Okay, let me see. You can see the perilymphatic fluid bulging, pulsating a little bit. So I think it's pretty good. I want to enlarge it a little bit more. Now, which is now 4 millimeter. 4.25. I think it's going to be 4.25. Alright, so I'm going to put the vein now. I'm going to put the vein over the fenestra, of course, as usual, just like for a regular primary otosclerosis. So this area is very, very small, very narrow. Trying to introduce the vein and to stretch the vein. I know that the fenestra is right here, so I'm going to stretch the vein here and I'm going to put the prosthesis there. Mesureur, s'il vous plaît. Yeah, there we go. This is the position of the shaft of the prosthesis. Okay, so I'm going to cut it at 4.25. And now I need to break the memory of the loop. There we go. So now the shaft is doing well. And I'm going to insert now the loop around the incus. It's not so easy. You see how difficult it is because this is so narrow. I need to rotate the loop here. And now it's fine, and now I can rotate, but I will need to rotate it on the other side, but it's pretty difficult. Tricky case. Changez-moi la tête, s'il vous plaît. You see the bone here that I have on my right is a very thick one, so this is why I don't have access to the loop so easily. Try to rotate on the other side. I think it would be probably more easy if I do it from the left. Right, like this. Yep, it's going to be better, I think. There we go. There we go. Now it's fine, and now I need to close it. This is the case where the trick of the two hooks is pretty better, because the curved forceps would not work here. It's too narrow. And even with the two hooks, very tricky. There we go. Okay, fine. And now I need to check a few things. The final position of the shaft, looking for the bending sign, and asset, s'il vous plaît. Now you see if I move the manage, for sure the prosthesis looks fine and mobile, but I want to be sure that the shaft is located within the fenestra. So I'm going to stretch the veins, but it looks good, and now you see the bending sign. You see that, so it's pretty good. And it's flexible, it's going down. Alright, so it's done. I need now to reposition the flap, and it's going to be fine with a mirror cell within the external auditory canal. C'était combien de speculum là? 6.5 millimeter diameter speculum, but everything was tricky and narrow over the window. Allez-y. So thanks very much for watching this, I think, interesting case, and I hope you enjoyed it as I did. Thank you.